So I'm Todd Wagner. I'll just jump right in. So it's a pleasure to be here. I'm at Stanford as well. I didn't know Dr. Lee, but it was a very interesting conversation that she was just having. And I wish I could be there in person, just to learn more about all the work that you're all doing. So I've been asked to speak on the economics of implementation. I'm a health economist here at Stanford, and I also direct a center at the VA. And I've been in this field for about 25 years. But I will admit that health economics methods talks are always tough. And I will say that I was nervous about this, and Steve and Anita were great. They said that you all enjoyed math and detailed equations, and that you would be engaged in asking great questions. That said, it's been a couple years since I've been to Cleveland, and I wish I could be there in person. So this is a picture many people just glaze over when I talk about econ methods. So I wanted to take a moment and talk about something totally different. Restaurants. And I like talking about cooking and restaurants. For me, cooking helps me relax. And I love watching shows like Top Chef and the Great British Baking Show. It's one of my vices. Also, I find that there are some insights in healthcare that we can gain by looking at restaurants. If you've ever worked in a restaurant, they're just brutally competitive. The margins are thin, the hours are long, they can be incredibly stressful. I'm really somewhat in awe of people who decide that they want to open a restaurant. Now, the past few years have been tough on restaurants. An estimated 90,000 went out of business during the pandemic, and Cleveland, as you know, was not immune. You lost places like Fire and Flying Fig and Spice, and I noticed that Simply Greek on South Euclid was no longer there. And you might ask, like, how did this happen? And it turns out that the market is really just a dispassionate boss. And to survive, a restaurant needs paying customers. And customers only go to places that they value. Value can be convenience, it can be quality, it can be ambiance or the speed of service. If it's poor value, you simply just don't go back. And value means different things to different people. And when enough people value the restaurant, it can survive and even thrive. You are really the judge of whether it's a good value. The market really provides just continuous feedback to the restaurant. So interestingly, restaurants that exist don't need implementation science because the market provides that function. The exception really is Gordon Ramsay's show, The Kitchen Nightmares. He worked in failing restaurants and told the owners quite brutally what they did wrong before they went out of business. And like I said, I like talking about restaurants because it defines value in a way that we all understand. In healthcare, it's really quite a bit harder because fundamentally the market doesn't work. Creating more competition, which has been a long-standing goal of administrations, is helpful in some regards, such as reducing prices, but it really doesn't solve all the problems. The quality gaps are still there, and people can't determine what they need to buy without the help of a clinical expert who may or may not be always having their best interests in mind. So a very famous health economist and former colleague of mine at Stanford by the name of Ken Arrow examined some key characteristics and wrote a paper on why there is market failure in healthcare. And that paper, I show you the picture here, was published in 1963, and in part because of that work, he won the Nobel in 1972. Now, that was 60 years ago, and we haven't figured out how to make markets work. And to be honest, I'm not holding out much hope. In fact, Ken's work influenced my dissertation. So in the late 1990s, we were in the dot-com era. And if you were around then, you'll recognize the now infamous Pets.com puppet. This was the pet food store that was valued at billions of dollars, then abruptly went bankrupt. At that time, I was interested in whether more information disseminated broadly through the internet could help consumers. We now have lots of medical information on the internet, but the market is still broken. As Ken described, it's related to several unmovable factors. In that regard, healthcare is nothing like restaurants. So a few years after I finished my PhD, the IOM published the landmark report on the quality chasm. I have a lot more gray hair today, and unfortunately, the quality gaps still exist. Healthcare leaders have more data than ever, but that hasn't fixed the problem in healthcare. So naturally, they called in the experts for help. For implementation scientists in the room, that's you. And that's the core vision of a learning healthcare system. And that's the basis for implementation science. Your charge, in some degree, is to fix the ship. In that conversation between leaders and implementation scientists, frequently there are questions about costs. And that makes sense. These leaders have to make decisions within a budget. Do they hire CT surgeons like Faisal Bakeen? Do they buy major equipment? Do they start a remodel? Or just save their money? These are tough questions. And honestly, a bad decision creates inefficiencies that can persist for decades. For example, if a health provider buys 3 MRIs and one remains idle, they have still spent that money on the extra MRI, and it really won't appreciate in value. And when I was hired at the VA in 1999, one of my charges was to do my own research, but my other charge was to support economic evaluations alongside multi-site clinical trials. The dominant question was whether treatment was cost-effective. That is, should society pay for that treatment? And at that time, there were some recommendations set out in the Gold Book. As you can see, not only was the cover gold, but the first author was Martha Gold. And the Gold Book really encouraged analyses from a societal perspective using lifetime costs. This is very much what you might think of as a population health approach. And over time, I saw fewer and fewer traditional trials. And if you're thinking traditional trials, think of these as sort of like the equivalent of a FDA phase 3 trial, a large efficacy trial. And I saw more and more implementation trials. What I noticed is that the economic questions morphed. While the traditional trial was interested in cost effectiveness from a societal perspective and a lifetime cost, the implementation trial wasn't. The trials struggled with that. They wanted shorter term evaluations with more focused perspectives, mostly because that's what the decision makers wanted. The idea of a budget impact analysis came up quite repeatedly. Luckily, the International Society for Pharmacoeconomics and Outcomes Research created standards for budget impact analyses. And so we started using these. And then quite in step, I realized that these were making assumptions that I was uncomfortable with. So they were just, the idea was that you're swapping out one drug for a different drug. And the more that I worked on many of these projects, the more uncomfortable I felt about applying these sort of standard BIA methods to implementation science. So drugs in many regards are not like implementation strategies. You can swap out drugs. Often this is seamless, but identifying and routing stroke patients in a system-wide change is anything but seamless. In fact, what you're trying to do is change the entire system. So I started working to create BIA methods for implementation science. And a group of health economists and implementation scientists gathered in December 2019 in DC. And up until that point, I was traveling to DC about once a month. And that was the last business trip I took for a couple of years. And the world changed in those years, but our group just switched over to Zoom. And I'm going to just summarize what we've learned from that group. From my experience, implementation scientists typically ask or see 4 economic questions. And I've just ordered these in what I think of as typically the most frequent sorting of those. The first question is, what is the cost of implementing X? And here I just use X to be any implementation strategy or implementation program that you're trying to launch. The second question is, what is the effect of implementing X on economic endpoints? And most typically, those would be something like cost or utilization. And obviously, utilization and costs are correlated. The third question that kept coming up is, what is the budgetary impact of implementing X? And then often it's replicating X to another site. And then more recently, I've seen questions about, is X sustainable over time? And can we make it more efficient? So let me just sort of dive into each of these 4 areas, because you'll probably see these more and more. So in question 1, the goal really is to estimate the cost of the intervention and implementation. You're going to find a lot of terms being used out there, but let's just group them all together. Essentially, they're doing the same thing. You spend your time trying to understand what people did with their time, and you assign a cost to that time. I call that microcosting. To answer this question, you really don't need a health economist. What you really need is a diligent RA. The RA is going to have to track people's time and be a hound dog. Ideally, you want someone who is obsessive compulsive and isn't going to quit when people stop responding to emails. I don't mean to imply that there aren't some interesting, more nuanced, interesting economic questions here, but the vast majority of the time depends on how precisely the RA tracks the time. If the RA does a great job, you will have accurate data, you'll have precision to be able to measure what's happening of implementation stages over time and perhaps measure some subgroup effects. Just so that you aren't surprised, most health economists I know aren't interested in doing this. So if your grant includes a section on costing, don't be surprised if you can't find a health economist to work with you. So the second question, what are the effects of implementation? Happily, health economists will often collaborate with you to answer this question. We love these kinds of questions when paired with big data. We're happy to talk about methods. We have lots of tools in our bag of causal inference methods. We're happy to be part of the team, and we appreciate qualitative and mixed methods in this regard. So let me show you an example of what I mean by one of these studies. So here is a study that a colleague of mine, Kriti Gujral, did in relatively short turnaround. The VA sent around tablets with cell phone coverage to veterans who were identified as needing mental health care. Now, this was during COVID, so you can imagine that people weren't easily accessing face-to-face care. And Kriti had information on who was sent the tablets and a control group that weren't. And she tracked cases and controls over time using administrative data in the VA. The graph on the right shows the mean difference between these two groups, so between cases and controls over time. The vertical line shows the timing at which the tablets were distributed. On the left side of that, no one got a tablet. And it's relatively reassuring that the trends are largely parallel and hovering around zero. So the mean difference between the cases and controls was zero. Thus, in these negative time periods, the groups look quite similar. And then after the intervention, the period to the right of the vertical line, the intervention group that got tablets had a large increase in video visits. Intuitively, that makes sense, and that's what they were hoping to see. Now, Kriti just extended that to look at downstream effects, and she looked at utilization. And the first thing she looked at was ED visits. And so here on the same type of graph, you get to see that the tablets prior to, or the people prior to getting the tablet looked relatively similar. Again, it's hovering around zero. And then after the tablet distribution, you have a decrease in the use of ED visits. Now, it doesn't mean, for example, that these are causally related, but it provides what we think of as indications of causal evidence. And she went on to look at hospital care and then get into some subgroup analyses too. Again, it's relatively easy to do these analyses with big data. So question 3. We get a lot of questions about budget impact. And to be honest, what the decision maker really wants to know, is it going to save them money? And they might often not say that because it's not always politically correct to say, I want to save money, but that's often what they're asking. I would say there's 2 approaches to address this question. The first approach is to create a decision model, and I have an example of one just on the right. The choice in this example is surgery or medication, and you have probabilities of having an event. Those are the orange circles, if you will. Each node at the right can be associated with an outcome and cost, and you can roll up this to determine the optimal decision. Here is the shocker for a lot of people. Most people are surprised when I tell them that health economists generally don't create cost-effectiveness models. And what we typically see is that decision scientists or decision modelers trained in decision science and operations research, a field of engineering, are often the ones who do this. Again, if you ask a health economist to create a model, don't be surprised if they say no. We're just not typically trained in that. Another way to approach this question, aside from the sort of decision model, is really to go back to question 2 and focus on the methods that Kriti used. If you show the intervention decrease emergency department visits and hospitalizations, immediately you have insights into savings. So you sort of have 2 approaches here. Now, the newest kid on the block is if the intervention is effective, then there's often questions about efficiency and sustainability. Like I said, this is probably the newest area of research. Frankly, I'm actually excited about it. So let me just introduce you to the production possibilities frontier. So this is a curve. This example was adapted from Amitabh Chandra's work. It's a great paper if you haven't read it. On the y-axis is health. This is what we're trying to produce. On the x-axis are the resources that we invest to make health. So in some sense, the graph just represents the relationship between spending and health outcomes. Now, all the points on this line represent efficient points of production, given our current skills and knowledge, sort of our know-how. We as society can produce more health by spending more, but there's diminishing marginal returns, and we can't produce above the line currently. We just don't have that technology or know-how yet. Note that the gains in health from moving from point B to point C and from E to F use about the same amount of inputs or resources, but the gain in health is quite a bit different. Put simply, investments that move us from B to C is more efficient than moving from E to F. Cost effectiveness analysis is just a formal way of showing that relationship. The relative gains can be shown by the tangent lines, and I've just sort of imposed those here. Point E and that tangent line is often referred to as the flat of the curve because at that point you're getting very little benefited health from investments. Now, society, each country can decide where it wants to be on this curve, and they can do so explicitly like the UK, or they can do it implicitly, sort of like the US. Other high-income countries don't spend nearly as much on healthcare as we do, but they have better outcomes. Just to put that in context, we spend 17% of our gross domestic product on healthcare. In total dollars, that's $5 trillion, or approximately $14,000 per capita. So this is sort of what motivates a lot of interest in cost-effectiveness analysis. Now, if you're an implementation scientist, you might say, why am I showing you this curve? Well, so the couple thoughts on this is, here's where you get to see where you might place on the cost-effectiveness analysis, but let me show you the next slide. So the production possibilities frontier can also just as easily be used to describe individual organizations rather than societies. And you get to say, where should the organizations invest? So think of Case Western or Cleveland Clinic. In this graph, think of each dot as an organization. The questions facing organizations are different than those facing societies. Each organization has different constraints and opportunity costs. Case Western already has its hospital, its capital equipment, its existing labor arrangements and contracts, its rules. When we make investments, we need to consider what we think of as typically fixed and what is variable. Let me also introduce another type of inefficiency. It's not so much just moving along the edge of that curve, but now look at these green dots. These green dots are technically inefficient. So points G, H, and I are all organizations that are inefficient at producing health. These organizations could use the same resources to make more outputs, for example, moving point H to point D, or that we can cut costs and produce the same outputs and move point H to point A. Both of those would be better choices than staying efficient for organization H. Now, if I were talking about restaurants G, H, and I would be in trouble unless Gordon Ramsay were there. They may just go out of business. In healthcare, that's very unlikely that these places will go out of business. So it's our job to help them. So implementation scientists are increasingly being asked to help the green dots move towards the frontier. I would argue that cost-effectiveness analysis is not helpful here. This really involves analyzing efficiency and helping G, H, and I move to the frontier. So let me give you an example. Hopefully it'll be a little bit more clear what I mean. So here's an example. So the NCI wanted to challenge their cancer centers to increase smoking cessation. Think of smoking cessation as the good that we know is cost effective, and they provided funding to each center. The centers could choose their own implementation strategies, and they measured each in relative to reach and effectiveness. So the natural question at the end of the trial was, which sites did better, and can we help these sites do better? The answer, it turns out, is not cost effectiveness analysis, but it involves plotting these 16 sites across the production possibilities frontier, what I just showed you. And you get to see where each of these sites lay, and you get to figure out how do you feed that information back to the sites. Now, at the time that Pluta and colleagues were publishing this article, I was working on a similar paper, methods paper with Kees Humans, Ramsey Saloom, and Doug Levy that is now under review. And interestingly enough, I was also working with another team, non-implementation scientists, to develop methods for measuring efficiency in primary care clinics in VA. So for me, the Pluta paper was sort of a light bulb moment when I realized that there's a link between what I think of as traditional economics and implementation science and efficiency. And I really do think that that is the right path forward when we know that the intervention's effective and we're just trying to get it implemented more widely. Now, it's not to say that efficiency analysis is going to be the end-all, be-all of every study. You need many sites, the more the better, so that you can sketch out this curve. You also need to measure costs and outcomes, and you can do so it doesn't have to be annual time periods. You could look at monthly, and you could just then think about how to feed that information back to the sites. In many regards, in some sense, you're simulating the market. Sites or organizations that are struggling can then pivot their strategies, cut their costs, or pull the plug entirely and invest something else. So maybe it's not smoking cessation, maybe it's breast cancer screening, or some other thing that they think is valuable. So that group that met in 2019 has published about a dozen papers so far. Our group still meets quarterly. And the last time we met, I suggested a path forward for feeding back this information to the field. Enola Proctor has been on us to think about how we train the next group of scientists. So it's perfect timing for this talk. Now, these 4 recommendations are just my personal thoughts. My first recommendation to you is start with question 2. Is the intervention effective? Measure the effects using economic variables, ED visits, hospitalization, outpatient visits. I would say start with the utilization variables. One, it gives you insights on mechanisms, which are important. It also correlates with costs, but using cost data are sometimes harder to find and have some challenges with them. But by using data from your organization that wants to improve, your results are really relevant to them. These methods are particularly powerful when paired with administrative data. So in VA, it's easy because we have 170 hospitals and 1,100 clinics. We can employ these methods quickly. If you only have data from 1 or 2 hospitals, you may need to be creative. I've seen increasingly people working with states to get all-payer state data and being creative with how they're thinking about their control sites. So that's my first recommendation. My second recommendation is if the implementation effort is effective, then I'd focus on efficiency. I would not try to estimate the cost per quality adjusted life year. I honestly think we'll see fewer and fewer of those at CERC and D&I conferences because the results aren't that interpretable or meaningful for implementation outcomes. I don't know what it is to say it costs $10 or $20 per person reached. That's a really hard incremental cost effectiveness ratio. My third recommendation is be cautious of just estimating the cost of implementation. And estimating implementation costs can be informative, and you'll actually need to do it for efficiency analysis if you get there. But alone, most people want to know what they get from that investment. It's not just purely the cost. The other thing that I find is that cost analyses can hide who is involved. And so I've been encouraging people to think a little bit more when they present cost analyses to talk about whose labor is involved. So implementation effort may only take an hour or 2 of a primary care provider's time. So it isn't that expensive when it put in dollars, but primary care physicians are tapped out across the country. They are working pajama time. So how are they going to add something else to their plate? What are they going to give up? And so if you can not only present the information on cost, but talk a little bit about who's doing the work, that's often really helpful for decision makers. And then finally, I would suggest you avoid creating the decision model on budget impact. So here's the figure of sort of the chasm. It's really hard to find the right data. Often you're using data from other hospitals or other systems. So you have to make these assumptions. Those assumptions, and I've talked to a lot of people, can be very unnerving. And so while the decision maker may want to know the budget impact, you often have to create a cost effectiveness analysis to put the budget impact analysis in context. So implicitly, if they just say, give me a budget impact, you're doing more than that. And then finally, we really struggle to publish these. When I think of top tier journals, they don't really want to publish a paper that's specific to Stanford Hospital or to a specific hospital. They want something that's broader than that. So again, it's really hard to make use of this in a useful way. So just in summary, for me, the path forward really involves understanding effectiveness and efficiency. And cost effectiveness is super well known, but with implementation science, I think we're going to pivot away from it. I think we're going to start asking some questions that are much more in line with what we've been doing in economics, which is sort of the causal effective things, really trying to get into the meat of the mechanism. Why is it working? And then if we end up doing that, and if we find it works, we're going to be much more interested in efficiency. I will say that the field is still relatively young. So you have lots of opportunities to learn and contribute. I have a slide next just on some of the papers that you could read, but there's clearly a huge opportunity to make advancements in the field. And so I think the field is wide open for that. It's been a wild ride for me. And so I just wanted to make sure I acknowledge the people who have been super supportive, and that's, Tees, who's in the UK, and Doug Levy, Ramsey, Heather at NYU, but you can see the list goes on. And I have some funding through NIH and CTSC here at Stanford, and a bunch of VA funding. So I was told to keep this simple. As you see, I had no equation, so I will stop there and just sort of turn to questions. And I know Stephen and Anita have some questions for me.
Thank you so much, Dr. Wagner. Of course, we had an introduction prepared for you, and but it also worked well that you just went straight into the presentation, and we do really appreciate all the recommendations that you've given at the end of your talk. As you've mentioned, my name is Steven Marciano, and I'm sitting alongside Anita, and we have a number of questions here. Of course, among the recommendations that you've made, you've kind of talked about why we should focus on a number of areas and why we should not focus on others. But I just want us maybe to talk a little bit more about budget impact analysis, because this is something that's talked about frequently, but within the field of implementation science, this is not done frequently enough, in my view. So maybe if you could kind of explain a little bit more what some of the challenges might be, why this might be the case, why we don't see a lot of budget or budget impact analysis not being done in implementation science. Thank you.
Yeah, thanks, Stephen. It's probably partly my fault. So for a long time, we were getting asked to do budget impact analyses. I was suggesting that was the route forward. I have some papers that we published in Medical Decision Making. In the end, I think it's a really challenging analytical system, especially, as I said, when you're modeling it. So first, let me talk about budget impact analysis from the drug perspective. With drugs and with ISPOR, we have a pharmacy distribution system. So we're really just swapping out a small piece for another small piece. And I don't mean to trivialize it, but in some sense, when we think about implementation science, and I gave the example of stroke, we're redefining a healthcare system for ischemic stroke. We want alteplase on board within 6 hours of onset of symptoms. And you really have to think about how are patients getting that information? What's happening in the emergency department? How is that getting translated into MRIs? And so it's much harder than just saying, oh, let's just swap this out. So the mechanics of the algebra are not so simple. If we're interested in budget impact analysis, and I think that there is still this interest in understanding, am I saving myself money? I think that utilization data are often an easier way to do it, to say, did it save the utilization that I'm interested in saving? Did it reduce hospitalizations? Did it reduce ED visits? But that should also generate a conversation with the leaders to make sure that the endpoints that you're looking at are the same endpoints that they're interested in saving. Because if you're interested in, sort of, did it save hospitalizations, and they're not interested in that, again, that might be a disconnect and you're trying to change the wrong endpoint.
Thank you so much. And again, your talk was very informative and wonderful for us to hear. I think in implementation science, a lot of us in that space aren't focusing on cost at all. And I think it's just so important to just have someone like you with your experience tell us about this. And so an earlier discussion we had today was about operational and research alignment. And my question is, some of this data that you suggest that we should be using with cost and measuring efficiency, looking at cost and outcomes to measure efficiency. Where does this data sit? And can you give us kind of an experience about how you have accessed this data and collaborated effectively as a researcher to obtain the correct data for your analyses?
Yeah, so that's a great question. I will say a number of years ago, I was giving a talk and I got off the podium and a hospital director came to me and asked me, he said, and quite honestly, he said, "Why are you always lying?" So it was an international talk, so the English was a little bit, but he was basically saying, "Why do you always lie to us?" And I was like, "What do you mean I'm lying to you?" And he's like, "Well, you always tell me it's going to be cost effective and it never saves me money." And so at first, I think I was probably defensive, like most people would be, and that sort of, and I tried to think about well, cost effectiveness, often there's a benefit and an added cost. And what I think there was also was just the broader disconnect between what their objective was, which was honestly just trying to save money and hoping that cost effectiveness would save them money. And so what I've been really working on, as you pointed out, is trying to find data sets specifically from the organization that's implementing so that I can understand what's actually happening there. So if it's happening at Case Western, it would be, can we get utilization data from Case Western? I would say it's often easiest to get it from the intervention sites because they're happy to contribute. They want to know this. It's the control sites that you struggle with. And so in that case, is it Case Western? Is it Cleveland Clinic across town? It's not even really across town, it's down the street. Or is it, Ohio data broadly? We've been working with a lot of all-payer state data to try to get at, okay, what's going on, to get us a sense on what's happening in the state more broadly. And you get to see sort of all of that. So that's been very, very helpful for us in terms of data sets. I've seen a lot of regional initiatives, but I've struggled, to be honest, with Stanford. They are still a bench science institution. And when I talk to them about building population health data sets, they're like, "Oh, that's liability. I don't really want to, think about data use agreements. They'd much rather just do cells and stuff." And it gets me very frustrated. But I think you have to be creative about how you build your data sets.
Thank you.
Just another question. Thinking about the shift that's happening within the U.S. healthcare system in terms of costing, cost effectiveness analysis, and the recommendations that are being made thereof, but also at the same time looking at implementation science as a new field, and then also considering the different financing mechanisms that are there. As someone who has learned about the different financing systems that are out there globally, in the US, it's kind of a mixed bag. In your talk, you didn't say anything about the role of financing when it comes to its importance when we're thinking about implementation and the future of anything that maybe we might want to do when it comes to implementation research, whether you want to talk about efficiency, you want to talk about anything that's important in that regard. I'm wondering whether this is something that you might want to touch upon, like if there is an intersection between implementation and financing that you want to highlight to our audience.
Yeah, yes, thank you for that. So I will say, you're right, I didn't talk about it but understanding the financing of the system is really critical for your success or the success of any implementation science. So I think of financing as sort of like the current in the river in which you're swimming. And sometimes you might be trying to implement something that is counter to the financing of the system, and that's really like swimming upstream. And it can be a very swift current that it makes your implementation less successful, or you can be swimming downstream and it makes it much more successful. So when I sometimes give a talk, there's an example I give about ICUs. And so we generally know that about 40% of ICU admissions are not for life-sustaining care. They're for people who are dying, or the doctor admits the patient there because they want a little bit more attention on monitoring, but they don't really need life-sustaining care. And as an implementation scientist, you might think, oh, let's de-implement this. Let's sort of reduce the size of the ICU. But you have to think first about sort of how is that organization getting financed? If they are getting rewarded for moving those patients into the ICU. Perhaps they have most of their contracts under fee-for-service or some sort of blended fee-for-service. They might actually really like the ICU keeping it at full capacity versus an organization that has a lot of at-risk contracts that would like to shrink the ICU to make it much more smaller. And so those are very different implementation effects, because if you're swimming upstream against this organization that loves the ICU, they are never going to take your recommendation. So you really need to talk a little bit about, with the leaders, not only what are the outcomes they're interested in, learn more about how their financing works at that site. Great question, Steve.
Thank you so much. Your response just highlights again the importance of context, measuring context in any implementation work, because you think about cost and you think, well, that's okay, we can just measure that. And there may be not as many influences as you might be thinking about uptake of a particular intervention by a provider. But the importance of context and even understanding cost is so incredibly important. And so the mixed methods work that you referred to earlier, definitely has a place even when thinking about cost and within implementation. I have a question about de-implementation. That's a term that comes up a lot, and although we haven't focused on it this morning, thinking about it in relation to cost. Could there be a cost benefit, improved efficiency with de-implementing, and do you have any thoughts about that?
Right. I didn't cover de-implementation at all. To me, it fits into this question mostly of efficiency and sustainability. And I think I would highlight this issue of rules and regulations. So an economist thinks about rules and regulations as adding cost to the production costs. They make the system more expensive to work. And as an example, I have friends here in Silicon Valley who work in startups, and they love it. But they love, in part, the lack of rules. You make things up as you go. You just innovate. That, in their mind, is super, super efficient. And that may work well when you have a handful of people working in a close space and everything is synced. But at some point, you need processes. Some of those processes turn into rules. Some of those rules have a cost, and some of those rules we don't ever de-implement. And so not to say that the rules don't benefit people in the organization, I'm not denying it, but they do add a cost. And we think of those rules as fixed. So take, for example, for a long time, we had to get prescriptions for hearing aids. And maybe that made sense years ago, but it doesn't make sense today. And luckily, the FDA removed that rule. But even within our organization, we often have rules like, oh, you must get pre-op testing for this procedure. But if the procedure is a low-risk procedure, such as just a cataract, is that really beneficial? It just sort of adds cost. And I had some colleagues here at Stanford, Farrell and Arun and Arnie Milstein, and they were trying to ask a deceptively simple question. They were interested in heart bypass surgery, and they were just sort of curious about why is it so much cheaper in India than the US, all things being else equal. And it really wasn't a difference in wages. And what they found is that a lot of it was driven by regulations. So I think if you're really interested in de-implementation, the easiest place to look in your organization is the rules that we have that are just making it more expensive to do things that add up over time. And the other one that I hear frequently is implementation scientists, many of you probably want to tinker with your EMR. You're trying to think like, oh, how do we do this and make this implementation smoother on our EMR? And yet the organization has, because it's spent so much money on this EMR, they built these excessive barriers to do anything like that. In my mind, these barriers are sometimes just irrationally large. And now this is, in some sense, just predictable. And psychologist Danny Kahneman and Amos Tversky studied this in its prospect theory. So part of this is just sort of trying to understand how to de-implement many of these rules in a very bureaucratic system. I work in two incredibly bureaucratic systems. Any large hospital is bureaucratic like Stanford, but also the VA. And you just have to sort of figure out how to negotiate. But I think one of the challenges that we face in implementation science is how to de-implement some of these rules that really constrain us.
Thank you. Thank you so much. I do have a final question about so we have lots of people listening today who maybe are focusing on implementation science and haven't thought about costs. How do we start doing that? How do we collaborate with a health economist? How do we figure out who knows how to do this? How does the collaboration start when maybe you have an implementation researcher who doesn't know much about how to appropriately measure cost? How do we find a collaborator?
So, right, it's super hard, to be honest. And I think one of the things that's hard is that often you're writing a grant and you're like, oh, aim 3 is the perfect aim for the economist. Maya Barnett, who's a psychologist at UCSB, saw this so frequently, she studied it. And like I was saying throughout the talk, a lot of these questions are not a natural marriage between health economics and implementation science. So we think of like, oh, all health economists study money and do cost effectiveness analysis. But surprisingly to many people, we just don't. We weren't trained in that. And so you might ask like, well, what do economists and health economists do? And so Vic Fuchs, who's one of my former colleagues at Stanford and just a giant in the field, said that health economists really specialize in studying the effect of policies and programs where there's heterogeneity, substitutability, and financial constraints. So if I think back to that example that I gave you with Kriti Gujral, that's sort of the happy space for health economists. When we make these programs like the hospital readmission reduction program that came out years ago, there were many dissertations written on that. That's the kind of thing that people really get enthused about. So part of it is just asking the right question when you're trying to build these collaborations. And that's where one of those questions was like, focus on effectiveness. Because I think you're actually going to find a lot more opportunity to blend with economists when you say, let's think about, is this effective? And measure it on economic endpoints. Does it change the utilization and the way we think it's going to change the utilization? And I think that's a marriage that's out there that can be exploited. Not that you should exploit marriage, but no. Yes.
Thank you so much.
Thank you so much, Dr. Wagner. We know that it was quite early for you that side, but thank you so much for being available. We are quite on time, so we'll be moving to our next session. Thank you once again.
You bet. Thank you.
Yeah.